I'm talking about Chapter 23 drugs, and that's drugs we use to treat Parkinson's and Alzheimer's. And to start, I'm going to talk about Parkinson's and how it affects the body. So to talk about Parkinson's, I've drawn a diagram, and it's of the extrapyramidal motor tract because Parkinson's affects the extrapyramidal motor tract. The extrapyramidal motor tract are neurons in different regions of the brain that involve movement. And as you can see, there's some parts here. It involves the thalamus, basal ganglia, and ganglia just means it's a group of cell bodies. And also the cerebellum, we have substantia nigra, and it descends into the spinal cord. And if you have a transverse section of the spinal cord, it'll be a little region here. And those nerves travel down into muscles. And what the neurons are responsible for is that they control and coordinate postural, static, and supporting locomotor mechanisms. This causes contraction of muscle groups in sequential and simultaneously. So I know many times we take for granted things that we do, like our posture or lifting things, like how we're able to move around, but actually they're actually very complex, our movements. Many times, for example, to pick up a pencil versus picking up a book, we have to recruit a certain amount of muscles and muscle groups. And sometimes you have to suppress some muscles so to allow others to flex. So these neurons control the simultaneous stimulation of the certain muscles related to posture or the way people move. And in Parkinson's, that's the issue. And I want to talk about the imbalances that are happening, why Parkinson's, why this happens in Parkinson's. So the three imbalances, I have them here, and the neurotransmitters are out of balance are dopamine, acetylcholine, and gamma-aminobutyric acid. So the first one is dopamine. In people with Parkinson's, there's a decrease, and there's a decrease because you have a loss of dopaminergic cells, and what that means is cells that release dopamine, or that they make dopamine. So these cells are lost. It's not quite known why. They're located in the substantia nigra. By the time the symptoms of Parkinson's are seen, 80% of these cells are already gone. That's this part here of the midbrain. And this is bad because other cells, like the cells in the basal ganglia, they depend on dopamine to work efficiently. So when they don't have dopamine, there's less communication, and the muscles that need to be recruited or need to be stimulated aren't. So there's distortion of movement. The next imbalance is acetylcholine. So when there's a decrease in dopamine, we have an increase of acetylcholine, and that's because dopamine normally suppresses acetylcholine. And dopamine is to relax muscles, acetylcholine is excitatory. So when there's the imbalance of a decrease in dopamine, we have increase of acetylcholine, and that's excitatory, so it's going to stimulate muscles to contract that we're not trying to make to contract. The last imbalance we have is gamma-aminobutyric acid. Just like acetylcholine has a relationship with dopamine, gamma-aminobutyric acid has a relationship with acetylcholine. And what acetylcholine does is that it causes an increase in the release of GABA in neurons. So we get an increase of that, and as you already know, GABA is an inhibitory amino acid, and it inhibits neurons that lead to muscles. So for example, when you walk, you need certain muscles to walk, but since you're being inhibited, then you have less communication, less signaling to the muscle you want to move. So the four main signs and symptoms of Parkinson's related to these imbalances, because of these imbalances, are rigidity, tremor, akinesia. A means without, kinesia it's without voluntary movement. Sometimes you move, like for example tremors, you move without wanting to. Kinesia, I underline kin because like kinesiology. So if you see this word, it's related to movement. And you also have impairment of postural reflexes. That's because I said that you have inhibition and you have acetylcholine. It's excitatory, but it's also you're inhibiting the incorrect muscles, the muscles you don't want to inhibit. Okay, so what drugs are we going to give? The first drugs class we're going to give are anticholinergics. Why? Because we already discussed that there's an increase of acetylcholine. So we're gonna give anticholinergics. Cholinergic means like the parasympathetic system. So the release of acetylcholine. So we're gonna suppress the release of acetylcholine. Dopamine replacement. So we're gonna replace the dopamine that we have lost because of the loss of the cells that produce dopamine. Dopamine agonists. These stimulate the dopamine receptors. Monoamino oxidase B inhibitors. Monoamino oxidase is an enzyme that breaks down dopamine, and we don't want to break down dopamine because there's already been a loss. So we're going to inhibit that enzyme. The reason I've underlined B is because there's another enzyme that is monoamino oxidase, but it's oxidase A, and we're not talking about that one. That's a antidepressant. It suppresses monoamino oxidase A, which is responsible for breaking down tyramine and serotonin. So that's something else. B, the one we're given here is to inhibit MAO-B, which breaks down dopamine. Next, the last group of drugs are COMT inhibitors. COMT stands for catechol-O-methyltransferase, and it also deactivates dopamine. It doesn't break it down, but it deactivates it, and we don't want that either. We want more dopamine. So let's start off with anticholinergics. They're mostly used for drug-induced extrapyramidal symptoms, and now you know why they're called extrapyramidal symptoms, because they cause the extrapyramidal, like Parkinson's. They cause a reaction in extrapyramidal the motor tract. This is common with antipsychotics, so we're going to give these drugs to help combat those symptoms from those drugs. And the drugs are benztropine mesylate, that's the first one. And of course, since it's an anticholinergic, a lot of the contraindications have to do with suppressing things that are wet. Contraindications, so like if you're having a GI obstruction, you're not going to give these drugs, or prostatic hyperplasia, because they're already having problems urinating. So you don't want to cause more problems by giving them an anticholinergic. The next one is bipyridine hydrochloride. With this drug, there's tolerance with prolonged use. You shouldn't use it you shouldn't drink alcohol or use CNS depressants with bipyridine. A lot of the side effects are also anticholinergic, so you're going to get like dry mouth, constipation. Nursing implications are like help soothe with the dry mouth, give plenty of fluids, and give fiber to prevent constipation. The next anticholinergic is trihexyphenidyl hydrochloride. It does help with the drug-induced EPS and Parkinson's, but it doesn't help with tardive dyskinesia. Again, I've underlined kin, just to remind you that kin is like kinesiology, so having to do with movement. This drug doesn't help with that, but it does help with the Parkinson's. The book also lists diphenhydramine, Benadryl. It has anticholinergic properties, and we give this since it's a very useful drug, because sometimes there's older people who can't tolerate dopamine agonists, like the other drugs we're going to talk about, so we give them a Benadryl. So the next drugs are dopaminergics, table 23.3 in our book. Dopaminergics, the first one we have is carbidopa, levodopa. So remember, we've had a loss in dopamine, so we're going to try to replace that dopamine. And we have the drug carbidopa, levodopa. Why are they a combination drug? Because the carbidopa part of it prevents the levodopa to be converted into dopamine in the periphery. We want it to have its effect in the brain. So that's what the carbidopa does, and this allows the levodopa to cross the blood-brain barrier to have its effect in the brain. So side effects of it are GI, because the dopamine also affects the chemoreceptor trigger zone. So this causes nausea, vomiting. You could take it with food, but it will delay the effect of the drug. You also have nightmares, suicidal ideation, mental disturbances. For cardiovascular, you're going to have orthostatic hypotension, nursing interventions like get them up slowly, make sure they're not dizzy. For life-threatening, that's why there's a skull here. It's agranulocytosis, so you're going to be checking white blood cells. There's heart dysrhythmias and NMS, which we're going to talk about more in antipsychotics. That's neuroleptic malignant syndrome. And Dr. Rose told us to remember that it's hot, stiff, and out of it. So that's an adverse effect of carbidopa levodopa. But it's just a reminder for the following chapters we're going to go over. Something I would like to know if I was taking this drug is that the urine of the patient and sweat is going to be black. But just tell the patient that this is normal. It might just stain your clothes. But if I were the patient and I was taking this drug, please let me know so I won't like freak out, you know? So I just put that in there because it's kind of important, you know? This is supposed to be a lettuce because the book says to take it with low protein foods, or to avoid like high protein, because it affects the drug in your body. So low protein. If you take it with a monoamino oxidase A inhibitor, it causes hypertensive crisis. That's one of the major drug interactions. So the next one is dopamine agonists. So these aren't dopamine, but they do stimulate the receptors, the dopamine receptors. And the first one we have is amantadine hydrochloride. Amantadine hydrochloride. This is an antiviral drug. It stimulates the dopamine receptors, like I said. You do create tolerance. Some patients create tolerance. Although it has less side effects, the patients create tolerance. That's why sometimes we choose another drug. The side effects of it are orthostatic hypotension, confusion, urinary retention, and constipation. The next one is bromocriptine mesylate. This has more side effects, but it is more effective than these, and this was more effective than the amantadine and the anticholinergics. So we have bromocriptine mesylate. Do not take it with alcohol. The book just lists side effects for these, but maybe you could look them up. So the dopamine agonists, they're under dopamine agonists. Pramipexole dihydrochloride, pramipexole dihydrochloride, and ropinirole hydrochloride. Most of the drugs, you're not supposed to do abrupt discontinuation because you could actually increase the Parkinson disease that they have. Do not abruptly discontinue. So one of our last ones is monoamino oxidase B inhibitors. So the first one, selegiline hydrochloride. I have this under green because they both have giline. So monoamino oxidase B inhibitors are selegiline, hydrochloride, and razagiline. If you give them a large dose, it starts to stimulate the other enzyme that I was talking about, the monoamino oxidase A. So if they eat anything that's pickled, they're going to have a hypertensive crisis. The monoamino oxidase A that I was talking about, it breaks down tyramine and serotonin, but we'll learn about that in antidepressants. Here, basically, if you give too much of selegiline, you're going to have that same effect of monoamino oxidase A inhibitor. So you're going to have hypertensive crisis with giving people certain types of food if you give too much of selegiline. And the other one is razagiline. Okay, so the other drug class, they're COMT inhibitors. COMT was catechol-O-methyltransferase. And it's an enzyme that blocks that deactivates dopamine. It deactivates dopamine. So I actually like these drugs because I found like a kind of like a cool way to remember them. So the two drugs are tolcapone and entacapone, and yes, it's I'm gonna remember them like Al Capone, like you know, like the gang guy, because he's in charge of the dope, you know, like he's holding the dope. So he handles like the dope distribution. So I'm gonna remember them as using them for Parkinson's because they're gonna increase dopamine by inhibiting the COMT. So Al Capone, yeah. So we have the capones, tolcapone and entacapone. And I just like that, it has to do with dope, yeah, like, like drugs. But dope like dopamine, we're talking about dopamine. There's a decrease in Parkinson's, and we want to increase the dopamine. So it's going to inhibit the COMT, and therefore decreasing the dopamine. Tolcapone, usually we give this with levodopa because we want to prolong the levodopa, but a problem with these COMT inhibitors are hepatotoxicity, so watch for your liver enzymes. The other one is entacapone. This has the effect of stopping the on and off phenomenon, and I've drawn like a little chart, a little graph here to talk about what the on and off phenomenon is. So basically, here we have the symptoms of Parkinson's, and before they start taking the drug, it's here, and then once they take their drug, it decreases. But the off phenomenon, like they're off of the drug, so the symptoms of Parkinson's actually increase before their next dose. So what these drugs do is they provide for constancy. So you don't get that on and off effect between doses. Like it makes it constant. It doesn't make it like, oh, your Parkinson's symptoms are worse, you know? We don't want that. So it provides for constancy, these drugs, COMT inhibitors. Okay, so the last, we're actually moving on to a different topic now. I'm going to talk about Alzheimer's and the drugs. This is actually very short. We're going to talk about Alzheimer's disease. I'm just going to talk about a little bit. So there's many theories about Alzheimer's and what happens. The first one is that there's a destruction or a decrease in cholinergic. Cholinergic just means the cells that release acetylcholine. So we had the dopaminergic, which means they release dopamine or produce dopamine. These are a decrease of cholinergic, so you have less acetylcholine. So that's one theory as to why people develop Alzheimer's. The second is that there's neurotic plaques outside of the neurons. Third, apolipoprotein E4 causes a plaque formation. Theory number 4 is that B-amino lipoprotein accumulates in the plaque that was formed by the apolipoprotein, and it causes neural injury. And the fifth one is that neurofibrillary tangles with twists in the neurons. And I've drawn it here. So this is a normal neuron. The microtubules are fine, but here you can see that there's tangles. These are the plaques, the disintegrated dendrites, so plaques form, and that's why they start to lose memory. So these are the common symptoms of Alzheimer's. We have memory loss, confusion, they can't communicate, they become aggressive. And they're not aggressive because they're like aggressive people, it's just because they don't know you, you know, like who are you, why are you here, you know, because they've lost their memory, so that's why they become aggressive. Depression and psychosis. We have 1 through 7, we have 7 stages of Alzheimer's. I'm not going to specify them, but basically what happens is you start to get, there's an increase in memory loss, your personality changes, or the patient's personality changes, there's hyperactivity, hostility, paranoia, people start to wander, they start to wander through aisles, that's a common thing, and they lack the ability to express themselves. The only drugs we're going to give, the only drugs we're going to talk about, having to do with the first theory. So we talk about, I know a lot of things are mentioned here, but the only drugs we're going to give are to increase acetylcholine, and those are the acetylcholine esterase inhibitors. So acetylcholine esterase is the enzyme that breaks down acetylcholine, and we don't want to break down acetylcholine because we're lacking of it as it is. Well, the studies show that an increase in acetylcholine actually doesn't stop, but it helps with the Alzheimer's symptoms. And this has been proven in testing. I don't know how they found out, but so we're going to give acetylcholine esterase inhibitors. Acetylcholine esterase, or also called cholinesterase, is something that breaks down acetylcholine, and we don't want that to happen. So the first one is donepezil. I didn't put a lot of information. The next one is rivastigmine. An adverse effect are seizures, orthostatic hypotension. Something that's life-threatening is hepatotoxicity. A contraindication is liver disease, because obviously if one of the reactions is toxic liver, then a contraindication is going to be a liver disease. Seizures, yeah. So the reason they're seizures because if there's an increase in acetylcholine is excitatory. So if there's an increase in acetylcholine, you're going to be excited, you know, like, so seizures, like you're going to have seizures. That's why it's an adverse effect, and you want to watch out for that. Tacrine, hydrochloride, memantine. So all these drugs, except for this one, are for mild to moderate Alzheimer's. This is the only one that's mild to severe Alzheimer's. Memantine is mild to severe Alzheimer's. The rest are mild to moderate Alzheimer's. And the last one is galantamine. So these work by increasing acetylcholine. And that's it.